Hello everyone, I am Dr. Jennifer Meddings. I am an internal medicine physician at the University of Michigan and the Ann Arbor VA Hospital. We at the University of Michigan are very pleased to bring this short video called Leave Well Enough Alone, Avoiding Unnecessary Urine Cultures from the PRISM program. The topics we'll review in this video are 1. What urine tests are used to diagnose infection? 2. Why avoid inappropriate urine tests? And 3. When to order and not to order urine infection tests. So what urine tests are commonly ordered to diagnose infection? The most common test is the urine culture, which answers the question of which bacteria are in the urine, which type, and even how sensitive is the bacteria to certain antibiotics, which is a very useful test in patients who have symptoms that appropriately support a urinary tract source of infection, which we'll review soon in this video also. Please remember, this test does not distinguish clinical infection from chronic colonization without infection. Another common test is the urinalysis, commonly abbreviated as a UA, which only tests urine for cells, such as white blood cells or red blood cells, and certain urine chemistry tests, such as leukocyte esterase, nitrite, glucose, ketones, protein, etc. And if a urinalysis is ordered alone, it does not send an automatic culture test. This test is commonly used in outpatient settings as a screening test for possible urinary tract infection to inform the decision to start outpatient antibiotics in the patient who is not going to be under continued observation by healthcare workers while waiting for the urine culture to come back. This test is also used to test for other non-infectious conditions, such as kidney stones by looking for blood in the urine, or some types of kidney disease by screening for protein in the urine. New information to note is that it is no longer considered appropriate to diagnose and treat a urinary tract infection in a healthcare facility by urinalysis results alone. All UTIs that generate prescriptions for antibiotics should be confirmed with urine cultures so that antibiotics can be stopped if the culture is negative, and to check for how well the antibiotic chosen will treat the UTI, because antibiotic resistance is increasingly common, especially for UTIs diagnosed in patients requiring hospital or nursing home care. A third test available at some hospitals and nursing homes is known as the UA, or urinalysis with reflex to culture if indicated, which is potentially a two-part test. Part 1 is a standard UA testing for urine cells and chemistry, and Part 2 includes a urine culture test that is generated automatically if there are certain abnormal urinalysis results from Part 1 that are more commonly seen in UTIs. This UA with reflex to culture test is the preferred test at many facilities because it means that when the patient has a normal urinalysis result, which means a UTI is not supported, no urine culture will be sent. This reduces the occurrence of having positive urine culture results with an abnormal UA, which is more supportive of chronic colonization rather than a clinical UTI, but is often inappropriately treated with antibiotics. So, in this talk, when we are discussing why and how to reduce sending urine culture tests when not appropriate, we are also talking about avoiding sending any of these three tests to look for evidence of urinary infection when not supported by evidence-based guidelines by infection experts. So, why avoid inappropriate urine tests? Let's do this with a case. For case 1, Mrs. Smith is a 75-year-old woman with chronic urinary incontinence. She has developed a fever, muscle aches, fatigue, nasal congestion, cough, with signs of dehydration and malodorous urine. She has some tests sent, and her test results are positive for influenza A. She has a negative chest x-ray. She has an abnormal urinalysis, and this was on urine collected by urine catheterization due to incontinence, and this leads to a positive urine culture for E. coli. For treatment, she was given influenza medication, IV fluids, and also antibiotics for that positive urine culture. So what were the outcomes for Mrs. Smith? Well, she was improved from influenza with the antiviral and hydration, but she developed pain and hematuria from that bladder catheterization. She developed itchy hives, felt to be from the antibiotic, and she developed C. difficile diarrhea, which required readmission. So why did this happen? This was a case of inappropriate urine test requesting and ordering. It was inappropriate because there were no new urinary tract symptoms in this patient who had an alternative explanation for fever. Also, the urine odor and appearance symptoms, such as her malodorous urine, are no longer considered appropriate for ordering cultures. Also, postmenopausal women, such as Mrs. Smith, as well as elderly men and women, are at high risk for urine colonization, which yields positive urinalyses and positive cultures even without an infection. So in this case, as a quick review, there was unnecessary urine catheterization that has its risk itself of infection, discomfort, and urethral injury. Since that urine test was not even clinically indicated, there was also unnecessary antibiotic initiation for positive urine culture results, since there was an alternative explanation for the fever. And note, it is very difficult for clinicians to avoid tempting that start of antibiotics when there is a positive urine culture result comes back, and this is particularly common if the clinician who receives the result the next day was not the clinician who sent the test, so did not really know what the original symptoms were. On to a second case. Mr. Martin is a 78-year-old man with a chronic indwelling catheter used for urinary retention. Today, he has fever, productive cough, shortness of breath, with some confusion and cloudy urine. So his test results showed that he had hypoxia at 84% in room air. He had a right lower lobe consolidation on a chest x-ray with an effusion. He had a positive urinalysis with positive urine culture results for Klebsiella that was resistant to several common oral antibiotics. And for treatment, he received IV antibiotics targeted at both pneumonia and urinary tract infection, IV fluids, and some respiratory support. So what were the outcomes for Mr. Smith? Well, he was improved from his pneumonia, but due to the type of resistant bacteria in his urine, he was treated with stronger IV antibiotics than needed for the pneumonia alone. A PICC line needed to be placed for difficulty with access to complete his IV antibiotic course, and he developed an upper extremity thrombosis. He also developed some renal insufficiency that was felt to be related to the combination of antibiotics that he required. So again, this is a case where there was some inappropriate urine testing because he had an alternative explanation for his symptoms, which in this case was pneumonia. There was also inappropriate antibiotic use for positive urine culture results in a patient without urinary symptoms, leading to unnecessary PICC line use and antibiotic complications. So, in summary, why avoid inappropriate urine tests? Well, patients receive only risk and no clinical benefit when the tests are sent inappropriately. It can prompt unnecessary bladder catheterization to get that urine sample and its associated risks of injury and infection. It can lead to positive urine cultures when there is no clinical infection, prompting unnecessary antibiotics. These positive urine culture results often show resistance to common lower risk antibiotics, particularly in our elderly patients or chronically catheterized patients, and this prompts the use of higher risk antibiotics or prolonged use of IV therapy or central line use. And antibiotics can be associated with allergic reactions, medication interactions, increased drug resistance, and the increased risk of C. difficile diarrhea. So on to our third objective, when to order and not to order urine infection tests. This slide shares a guideline that is published on the Blue Cross Blue Shield collaborative website that our group feels is very straightforward. and applicable to the patients in both the hospital and the nursing home setting. So in the first box, you first ask, should this patient be evaluated for a urinary tract infection? Now this guideline, you will see as a footnote, applies mainly to patients that are not the exceptions to the rule, which include those that are pregnant, those who've had a recent urologic procedure, those who have very complex urinary anatomy, such as nephrostomy tubes, urinary stents, and urinary diversion surgeries, and also patients who are neutropenic. Those are some of the rare exceptions where you could consider sending a urine culture without having clear symptoms. But for the majority of patients in both the hospital, the emergency department, and the nursing home, we start with the black box at the top. Does the patient have any of the following symptoms without an alternative explanation? That part, without an alternative explanation, is very important because, for example, if they clearly have an explanation, such as pneumonia or cellulitis, then these symptoms that are listed should not prompt a workup for a urinary tract infection. These symptoms include urgency, frequency, and dysuria, suprapubic pain or tenderness, costovertebral pain or tenderness, new onset mental status changes with leukocytosis, hypotension, or greater than or equal to SIRS criteria, which are defined in the green box below, involving heart rate criteria, respiratory rate, temperatures, leukocytoses. If they have a fever or rigors, if they have acute hematuria, and that is defined as gross hematuria, meaning you can see it in the urine. This is not simple cloudiness. And if they have increased spasticity or autonomic dysreflexia in a spinal cord injury patient. If they have any of these symptoms that do not have an alternative explanation, then the recommendations are to send a urinalysis, and if positive, send a urine culture, or in many facilities, as just discussed, you would send that UA with reflex to culture as a single order. You should also document your indication for sending the urine culture so the next clinician who sees that patient the next day and who receives the results of the urine culture will actually know why it was sent. And you can consider starting empiric therapy depending upon if the patient requires additional observation and their stability. If they do not have any of these symptoms that are noted above, the recommendation is to not send a urinalysis or urine culture. A few notes about the symptoms. So you see at the top of the box there are two sets of symptoms that I've highlighted in orange: urgency, frequency, dysuria, suprapubic pain, and tenderness. Please note that these particular symptoms are not considered reliable symptoms of a urinary tract infection if that catheter is still in place, because these symptoms can actually be caused by irritation of the bladder and the mucosa due to the catheter itself. And in many guidelines, including by the CDC, these are not considered qualifying symptoms for a urinary tract infection if that patient has a catheter in place, but could be considered as qualifying symptoms if that catheter has been removed and their symptoms are still there. Another important caveat to know is that when you think about sending that urine culture and your patient has been catheterized, you are recommended to change that catheter before sending the culture if it has been in place for more than 14 days because of the high likelihood of biofilm on that pre-existing catheter impacting your urine culture, and it could simply affect colonization. So, when is testing and treatment for positive urine cultures in an asymptomatic patient appropriate? These include pregnant women due to the increased risk of pyelonephritis and adverse birth outcomes, screening and treatment before a urologic surgery when mucosal bleeding is anticipated, such as a transurethral resection of the prostate. And some experts recommend screening or treating in the first 3 months after a kidney transplant because of the concern of the UTI increasing early transplant rejection, but there actually is no clear guidance on this from other guidelines. So, a few take-home points. First, what urine tests are used to diagnose infection? Know that the urinalysis with reflex to culture is preferred if clinically indicated and available in your healthcare facility. 2, why avoid inappropriate urine tests? This is because the risk outweighs the benefit when the test is inappropriate. reduce unnecessary catheterization for samples, antibiotics, and antibiotic complications. And 3, when to order and not to order urine infection tests. Avoid sending in the asymptomatic patient unless pregnant, urologic surgery, or a very recent kidney transplant. Do not send for urine odor or color changes, and do not send if there is a non-urinary tract explanation for the symptoms. Thank you very much for watching, and we hope you find this very useful.